Welcome to this explainer. Look, mastering thoracic radiotherapy as a resident, it often feels like you're navigating an absolute labyrinth of historical trials and super strict dosimetric boundaries, right? So, let's just cut through the noise. We're going to distill all this dense landmark trial data and those critical dose constraints into a high-yield, no-nonsense review perfectly tailored for your daily clinical practice and, of course, your board prep.
Here's our roadmap for today. We're covering diagnostics and toxicity, early stage and SBRT, locally advanced stage 3, post-operative RT, integrating systemics, and finally, we'll wrap up with critical dose constraints. Let's get right into it.
Section 1. Diagnostics and radiation toxicity. We're starting right at the baseline.
Okay, when we're looking at standard mediastinal staging, EBUS, endobronchial ultrasound, is really your go-to for most stations. Think stations 2, 4, 7, and 10 through 12. Now for stations 8 and 9, you're going to want EUS, or endoscopic ultrasound. And for those tricky stations 5 and 6, in the aortopulmonary window, that's where the surgical Chamberlain procedure comes in. But here is an absolute must-know clinical pearl for you. CT-guided transthoracic biopsy is explicitly not the standard for staging mediastinal lymph nodes. Don't fall for that trap on your exams or in the clinic.
So when we irradiate the thorax, radiation pneumonitis is that classic subacute complication we're all watching out for, usually popping up 6 weeks to 6 months post-treatment. Let's break down the cellular mechanics here. The initial radiation hit essentially knocks out your gas-exchanging type 1 pneumocytes. This loss triggers a massive compensatory proliferation of type 2 pneumocytes, which are desperately trying to restore the alveolar lining and pump out surfactant. But here's the catch. This very proliferation ends up culminating in a severe subacute inflammatory response. And that is exactly what we recognize clinically as pneumonitis.
Moving right along to Section 2, early stage non-small cell lung cancer and SBRT, the era of no surgery needed.
Looking back at the history, it really is a wild ride. In 2006, Timmerman's trial showed us amazing local control, but came with a really stark warning. Giving 60 to 66 gray and 3 fractions to central tumors, unacceptably high, severe toxicity. We're talking nearly half the patients hitting grade 3 or higher events. Yikes. So this led to a massive split in how we approach things. RTOG 0236 came in and standardized safe SBRT for peripheral tumors at 54 gray and 3 fractions. Meanwhile, RTOG 0813 had to do the heavy lifting, methodically dose escalating over years to finally find a safe, standardized regimen for those risky central tumors.
It's honestly fascinating to trace how our total doses and fractionations have shifted over the years. Notice the major pivot away from the danger zone. Pushing 20 to 22 gray per fraction for all tumors was just too hot. Instead, we see this beautifully nuanced approach emerge over time. RTOG 0813 essentially proved that hitting 50 to 60 gray delivered over 5 fractions, so 10 to 12 gray per fraction, really hits the sweet spot. You maximize your local control, but you successfully dodge those dangerous central toxicities.
Now you've got to love the head-to-head comparison in the Chisel trial. For inoperable, peripheral, early-stage disease, SABR just completely leaves standard conventional fractionation in the dust. I mean, look at these numbers. We are talking an 89% versus 65% 2-year local control rate. That is massive. And better yet, that local control directly translates into a very real, very significant overall survival benefit.
All right, Section 3, locally advanced stage 3. This is where those complex multimodality shifts really come into play.
If we follow the clinical evolution here, it's really a story of building on success. We started with CALGB 8433, which proved that sequential chemoradiation beats radiation alone. Then, RTOG 9410 took it a step further, proving concurrent therapy beats sequential. After that, RTOG 0617 locked in our modern dose standard. And then boom, 2017 hits, the Pacific trial drops, and it completely ushers in our modern era of immunotherapy integration. Just think about this massive leap in overall survival resulting from those shifts. It is literally jaw-dropping. We went from a median overall survival of just 13.8 months in the historic trials to an absolutely astounding 47.5 months in the Pacific trial. And how? By simply adding durvalumab consolidation after concurrent chemoradiation. This right here is a staggering, practice-changing leap. It completely redefined what we can expect for our patients.
So what happens when you're facing that classic clinical dilemma of resectable stage 3A and 2 disease? Well, these 2 trials, Intergroup 0139 and SPAT2, are your guiding lights. They practically shout that routine trimodality therapy offers zero overall survival advantage over definitive chemoradiation alone. In fact, Albane's Intergroup 0139 showed exceptionally high mortality, up to 26% when a pneumonectomy was performed after chemoradiation. The big takeaway? Surgery is really only beneficial in highly selected patients where a straightforward lobectomy is actually feasible.
Which brings us to an absolutely crucial clinical pearl for your practice, straight from RTO 0617. Say it with me. Higher dose does not mean better outcomes. Seriously, routine dose escalation to 74 Gray actually resulted in worse survival. Why? It was primarily driven by severe esophagitis and a spike in treatment-related cardiopulmonary deaths. Sticking to the standard 60 Gray is absolutely paramount. Don't be tempted to push it.
Next up, Section 4, Post-Operative Radiotherapy, or PORT. Let's look specifically at its role in N2 disease. The takeaway for PORT is definitive right now. Based on the recent LungArt trial, you should not routinely use PORT for resected N2 disease. Sure, PORT decreased mediastinal relapse, but it gave exactly zero overall survival benefit. And worse, it caused a significant excess in cardiopulmonary toxicity. So, what do? According to current NCCN guidelines, we reserve PORT strictly for highly selected, high-risk patients. Think extracapsular extension or positive margins. And when you do it, you must use modern, highly conformal techniques.
All right, shifting gears to Section 5, Integrating Systemic Therapies. Targeted agents, immunotherapy, the whole shebang. 80%. Let that sink in for a second. That massive number is the reduction in the risk of recurrence or death we saw in the ADAURA trial when the targeted therapy osimertinib is used after surgery for EGFR-mutated non-small cell lung cancer. Oh, and by the way, it also provided a staggering 82% reduction in CNS recurrence. It is a total game changer.
And we're in a rapidly evolving perioperative landscape right now. Checkmate 816 showed that adding neoadjuvant nivolumab to chemo jumps the pathological complete response rate from a measly 2% all the way up to 24%. Then there's the recently published LAURA trial, which showed an incredible 39.1-month progression-free survival when osimertinib is used after chemoradiation in stage 3 unresectable disease. Without it, just 5.6 months. Incorporating these agents isn't just an option anymore, it is drastically boosting our outcomes.
Finally, we arrive at Section 6, Critical Dose Constraints. This is the ultimate balancing act between those systemic combinations and local control.
Mapping out the 4 CDT phases we use to track tumor motion is so cool and, honestly, a great reminder for our daily practice. Just lock this in your brain for the boards. 0% represents maximum or end inspiration, while 50% represents maximum or end expiration. We absolutely have to intimately understand these phases if we want to create accurate internal target volumes. Okay, let's talk organ constraints, and let's use some mnemonic anchoring here to protect our patients. You should always use Dr. Palma's Keep 17 in mind rule for the esophageal V60. Keeping the volume of the esophagus receiving 60 Gray strictly under 17% is absolutely crucial to prevent that severe, sometimes fatal grade 3 esophagitis we saw back in RTOG 0617. Similarly, respect the heart constraints. Keep that mean dose under 20 Gray, because data from Spears and Wang show that cardiac dose directly, almost linearly, correlates with overall survival degradation. Don't mess around with the heart.
Here are some more rapid-fire constraints that are completely essential for safe central SBRT planning. First, you've got to restrict the trachea and bronchi V18 to less than 4 cc. For the chest wall, just remember 30 under 70, meaning the volume of the chest wall receiving 30 Gray should be 70 cc or less. That is how you prevent severe, debilitating chest wall pain. And lastly, keep the brachial plexus median dose under 69 Gray. Trust me, you do not want to cause permanent neuropathy.
Because look, ignoring target motion or pushing those anatomical boundaries has real terrible consequences. A classic example is a mediastinal tumor invasion causing left phrenic nerve palsy, which results in a visibly elevated left hemidiaphragm. It's a really stark, real-world reminder of the incredibly delicate structures we are navigating on a daily basis in the clinic. So, armed with this evolution of precision, the challenge is now yours. How are you going to practically integrate these landmark insights, trial outcomes, and strict constraints into your very next clinical plan? The standard of care has shifted dramatically over the last 2 decades, and mastering these specific details, that's exactly how we ensure curative outcomes while fiercely protecting our patients' quality of life.
Keep pushing for precision, and I'll see you in the clinic.